This program is brought to you by Stanford University. Please visit us at stanford.edu.
Our next speaker is Dr. Christopher Zarins, Division Chief Emeritus here at Stanford, worldwide authority and abdominal aortic aneurysm disease, and a true pioneer in the development of endovascular devices. Dr. Zarins, Dr. Fogarty developed and commercialized the ANUREX device and have been very active in this area in terms of understanding the problem as well as designing effective solutions. And Chris is going to bring his past experience forward and talk about design considerations for future device development. Chris, thank you for coming.
Thank you, Ron. It's a real pleasure. This has been a wonderful symposium. And I would like to, well, first of all, I want to disclose that I'm a consultant to Medtronic, which is a manufacturer of 2 FDA-approved devices, and I'll be mentioning those in my talk. I'd like to consider some of the issues related to device development and what we might expect in the future. And anytime you do that, you sort of have to start by looking at the past. Really the aneurysm story starts with some of the giants who really started open surgery. Most of you who read textbook know Charles DeBost as supposedly having done the very first successful aneurysm repair, but actually the first one was done by Norman Freeman here in San Francisco. And his patient was done 1 month before Charles DeBost. And what Norman Freeman did was he took an iliac vein and sewed it inside the aortic aneurysm. And he'd done this multiple times. And the patient usually bled to death. And the way he did the anastomosis was he put a couple of mattress silk sutures in and pulled the vein into the aneurysm. And then finally, on February 26th, it was bleeding so much he sewed the aneurysm shut, and the patient survived. So innovative, I guess, trial and error, but he was the first successful repair. Charles DeBost, after that, sewed in a homograft. And here we have Michael DeBakey 55 years ago. Here he is at midnight, the night before surgery, preparing a Dacron graft on his wife's sewing machine. Of course, he has a coat and tie on. They were very formal back in those days. As you know, he passed away this year at the age of 99. So the early development of how we treat aneurysms really was on the backs of giants, innovators, and it was in a trial and error fashion. And over the years, continued trial and error led to perfection of the operation of open aneurysm repair, and we've gotten to be pretty good at it. The whole sphere of surgery developed in terms of fluid resuscitation, ICU, anesthesia, clamp, sutures, and everything else. And this now allows us to very successfully place a graft inside an aneurysm, fix it with sutures, and the measure of success, same thing as it was in 1951. The patient survives. And that's the history of open surgery. It's the standard of care. It's what we judge everything that we do. And Dorothy, it's not FDA approved as far as I know. The big innovations, of course, came when Juan Perotti in 1991 did the first successful endoluminal repair. And of course, open surgery is a very big operation. The patients know it, the families know it, so the prospect of doing something with a much smaller groin incision was very, very attractive, and it caught on immediately. And this is Perotti's first innovative device. He took Palmaz stent, balloon expandable stent, and sewed it to a fabric Dacron graft, then used an introducer sheath, placed it in the neck of the aneurysm, expanded the balloon expandable stent, and with radial force held the device in place, and it worked. And this was a very new, unique, innovative concept. And since then, of course, it's been an explosion of innovation, and now we have had 6 FDA-approved devices. and I must give credit to Dorothy Abel for shepherding the process of FDA approval for the past 15 years to bring these new valuable devices to the market. And the way this happens now, as opposed to when open surgery was being developed, was this is done with clinical trials with comparison to the standard of care. The standard of care, of course, is open surgery. And each device is different. This is the Ancure EVT device, which was really modeled on open surgical device. It's very much like bifurcated open graft with stents on the top and the bottom with hooks on them to simulate or mimic a surgical anastomosis. And as you can imagine, it was a kind of a complex delivery system in order to place a device up from the femoral arteries with a bifurcation. And the complexity of the delivery system is ultimately what made that device not survive. Tom Fogarty's innovation was really the modularity, and this is the Anurex device. And these two devices were first approved in 1999 by the FDA, and subsequently the Gore device, the Zenith device, the Endologics, and the Talent device have been approved. And if you look at these, each is different. Each is unique. This is a stent on the outside with nitinol stents in the fabric on the inside. This is a polytetrafluoroethylene fabric with a stent. This is a bear spring suprarenal fixation device with hooks. This is the stent on the inside of a PTFE fabric with a bifurcated unimodular system. And this is the Talent device with a bare suprarenal spring. So how do you decide which one's better? They all work. They all withstood very, very careful clinical trials and scrutiny by the FDA in IDE clinical trials, and they're all available on the market. There are no trials comparing one device against the other. A manufacturer probably wouldn't want to do that, to compare one device against the other. The comparison is to open surgery. So how do people come up with these devices? How do they come up and how do they innovate, and on what basis do you design and create a device, and how do you actually know whether or not it works? Well, it works compared to open surgery, because that, of course, is the mechanism of FDA approval. Well, as we mentioned, FDA open surgery, the only thing you care about in open surgery is if the patient survives, because if you don't operate, the patient dies of rupture. And if you do operate, the patient may survive, or since it's such a big operation, they may die of complications of the surgery. So you balance the risk of the rupture versus the risk of the surgery. Well, the risk of an endograft is much less. In this comparison, the FDA, how does it decide whether it's the same or as good as open surgery? Well, you compare mortality and a major adverse clinical event, combined score, major morbidities. But then, as you all know, there are all these other issues with endografts that we never even think about with open surgery, even though we know that there are anastomotic pseudoaneurysms, there are aortoenteric fistulas, there are long-term complications. That all is sort of swept under the rug and not considered in general. So it becomes a confusing kind of a evaluation process, and it's difficult to actually compare one device against another. The prospective randomized trials haven't made it any better. In fact, I think they've muddied the water in many ways. Why? Because of a confusing, strange endpoint. And it's based on all-cause mortality. And, you know, all of us are going to die sooner or later, and if you follow two groups long enough, ultimately they're both going to die, so they're going to both be the same, and there's going to be no difference. But when you do look at these prospective trials, there's a threefold increase in surgical mortality in the open surgery group compared to the endo. So there's a huge benefit from Endovascular, proved by level 1 evidence in prospective randomized trials, but that's negated because of all these issues about late potential secondary events and the fact that you're going to die sooner or later. So how do you now differentiate with all of these grafts? I got this slide from Takoki. Takoki likes to collect devices. I got this from him in 2004. I'm sure this slide is twice as large now if I got an updated version from Takoki. But each of these devices is basically some construct of a stent and a fabric with a variety of fixation devices to hold it in place. To try to figure out which one works and how how one compares to the other is difficult, because on top of the differences in the device, you have differences in aneurysms. And we've been hearing a lot about that in this meeting, about small versus large aneurysms. Well, why are we thinking about small versus large aneurysms? Aneurysms aren't distributed in a bimodal distribution. They're distributed in a bell-shaped curve. And so you could pick any point that you wish to differentiate small versus large. And it happens to be most people pick 5.5 centimeters. And these are now 923 patients from the Anurix clinical trial, and you see more than 50% lie in the range of 5 to 6 centimeters. So that if you really wanted to look at a distribution and risks, you probably want to really think about small, medium, and large aneurysm as opposed to an absolute simple cutoff of small versus large. Because it would be hard to really figure out the differences if you look at this continuum of distribution. And we all know that the problems really occur mainly in the patients with the large aneurysms, and the problems are much, much less common in the patients with small aneurysms. Although we all know that small aneurysms do rupture, and that's not a predictable thing. But what we do know is that if you use an endograft and you do a clinical trial on a small aneurysm, you're going to get good results. So that if you now compare small, medium, and large aneurysms, the results, this is 5-year outcome results, are very good for small aneurysms. Freedom from aneurysm-related death is the worst for the large aneurysms. Does this mean you don't treat large aneurysms? Of course not, because the risks are so high of rupture in the large aneurysm. You do need to treat them. But if you want to have good results and you want to show that your endograft is good, you treat small aneurysms, because then your endograft will do well. And in fact, there are devices on the market which have been treated primarily in small aneurysms, and the results are outstanding. So if you look at now a Cox proportional hazard multivariate analysis as to predictors of outcome 5 years down the road, and you look at aneurysm-specific endpoints, such as rupture, aneurysm-related death, and surgical conversion, the only independent predictor of those outcome events 5 years later is preoperative aneurysm size. Again, you want good late results, you treat small aneurysms. For survival, there were other predictors. In addition to aneurysm size, patient age, surgical risk, and interestingly, peripheral occlusive disease were also significant predictors for survival, but not for these aneurysm-specific events. So aneurysm size is the primary determinant following endovascular repair. And if you really want to start to differentiate different devices and do comparative studies, you're probably going to need to more precisely define your groups at entry in terms of size. And the confusing group is that big middle group. And if you really want to compare small and large aneurysms and to find out what the real differences are, you probably ought to be comparing less than 5 to larger than 6 centimeter aneurysms. Well, I don't have time to discuss all of these issues of complications of endografts. So I'm going to just concentrate on one, and that is probably one of the most important, and that is migration. And some of the questions just came up on issues on stent graft migration. It's really what we need to do. The procedure really fails if the device does not stay in place. And so it's imperative that the device stay where it was placed and stay there forever. And in fact, all of the devices have some known incidence of movement. And if you look at the ID clinical trial data that's submitted to the FDA, each of the devices that have been FDA approved have some incidence at 1 year of migration. Now, can you compare these? No, because the trials are different, the definitions of migration are different, the methodology is different, so you can't compare one trial against another. But we do know that migration is an issue for all of the devices. And a lot of experimental studies have been done to try to determine why devices migrate and what can be done about it. And the big focus has been on the proximal fixation in terms of the neck, the angle, the size. How do you actually hold the top of the device in place? And can you measure the displacement force? Some of the very good early studies came from Malmo, Sweden. They did investigations in cadaveric aortas, and they used a force gauge to determine how many newtons of force it took to dislodge the device. And you could have frictional force, you could have hooks and barbs, and you can have other mechanisms. And it was clear that there was a difference at the sutured anastomoses were the strongest and took the greatest force to disrupt them, and that if you had hooks and barbs in there, the force that was required was tenfold higher to dislodge them if you had hooks and barbs in this system. Now, keep in mind the direction of the force being exposed here. And I've always thought, and maybe most people have thought, that as you have pulsatile blood flow, you have the downward pulse of blood, and with each pulse you have a force that's pushing that stent graft down, and you have to resist that downward displacement force, which is the direction of and the vector of that pull on the gauge that we have in the experimental models. So the proximal portion, how it hangs on, how it's either hanging on by radial force, by hooks, or other mechanisms, becomes an extremely important issue. Here in the Anurix clinical trial, the proximal fixation also was shown to be a very important point in terms of predictors of migration. The distance of the renal, of the stent to the renal artery was an important factor. Length of follow-up, that sort of makes a lot of sense, intuitively obvious. And one more thing that turned out to be an independent predictor, and that was the clinical implant site. And here we see the data for the migration versus the no migration, and the length was greater. And then also angulation turns out to be an issue. But the thing that was peculiar that took us, we couldn't really understand, was this clinical site variability. And this is from core lab data, and here we have 13 clinical sites, and the range of migration goes from 0 to 30%. If it were the device, it should be sort of about the same, I would think. And how can you use the same device and have such variation? Is it because the investigators didn't know how to use it? They were inexperienced, they were untrained? No, in fact, some of the lowest and highest users were here, and some of the lowest and highest users were here. So we couldn't explain it in terms of that. But one thing that was missing in the analysis, that we were looking at only the top of the device, the top of the fixation. We did not look at the bottom. And I like this slide because I had an opportunity to present data to the FDA panel in 1999, and I showed this slide. And Dorothy Abel was there, and I showed this slide as a great success. So look what a wonderful device this is. It's got no endo leak. And the measure of success, and back then all we knew was that if you excluded the device, if there was no endo leak, it was success. If you had endo leak, it was a failure. Of course, if something like a rupture happened, it was so rare and so unusual, but I mean, in terms of an endpoint for the trial, it was endo leak. And there was no endo leak. So, but you look at this, now looking at it, that looks a little bit funny. Is that really in the iliac arteries? Is that right? And now, in retrospect, I'll show you a follow-up of this patient a little in just a bit. So we started to now think, well, let's look at the bottom of the device. And in looking at the bottom of the device, we started to look at iliac fixation. And it's interesting, it took 10 years. 10 years for us to look at the bottom of the device. Not that we weren't putting iliac extenders and a lot of people were intuitively doing things, but in terms of a data analysis and a quantitative assessment. And the reason was the core labs didn't have it. It wasn't on the data sheets for the clinical trials. It wasn't written into the protocols. And with axial cuts of the CTs, the iliacs go this way and you can't see them very well. Didn't have three-dimensional imaging back in those days. So iliac data was not even considered. All we were looking at the top of the devices. So as it turns out, this is pretty obvious. You've got the device not up at the renals and the device is just barely into the iliacs. That's pretty bad. And nowadays, we go from the renals to the hypogastrics, and the data came out very clearly and unequivocally that the iliac fixation is important in terms of a predictor for migration. And if you had good iliac fixation, even if you had bad aortic fixation, you had no migration. If you had bad iliac fixation and good aortic fixation, you could get some migration. But if you had both top and bottom bad, you had a great propensity for migration. So the fixation, in retrospect, became extremely important. And of course, if you did have migration and now you added those extender modules later, you would stop the migration. And then we looked further with suprarenal devices. Same thing. If you've got longitudinal columnar support, you got to look at the bottom of the device. The iliac fixation is just as important, if not more important than the top, perhaps because it's the basis of the bottom that is holding the whole superstructure up. And experimental studies, the original ones were just straight pull-out forces, but if you put it in vivo with implanted devices, you again had a great increase in the displacement force needed. Now, all of these experiments, again, considered downward displacement devices. And all of the force analysis was based on the concept of downward displacement. But there's another factor that comes in, and that's neck tortuosity, which also turns out to be an important factor. So that led us to think, well, we've thought about the top of the device, and then we've thought about the bottom of the device. Well, what about the middle? There's this big space in the aneurysm sac, and you've got a device going through a big, open, empty space. So Stanford has tons of very, very bright students, and we had a student, Ben Raffi, who came and wanted a project, so he started to do this study as a senior honors thesis and won an award in the International Society Endovascular Surgery research competition this past year. And here's what he did. He simply looked at cross-sectional images, and he quantitated the movement of the stent graft in relationship to the vertebral artery. And this is a very simple linear measurement that you can do on any cross-sectional CT scan, and you can measure from time to time how far the device has or has not moved. And here we see such an example. This is a true lateral, and you see the distance between the vertebral body and the endograft. And you see 1 year later that this has moved a little bit. Does that mean anything? What is its significance? So he looked at 60 high-risk patients with both infrarenal and suprarenal endografts, And these are ones that were being followed very closely and had available 3D images for analysis. And follow-up extended out to 8.5 years with a mean of 4.5 years. And 27% of the patients at 1 year had evidence of 5 millimeters or more movement in a lateral sense. And 73% had no movement. So here's an example of no movement. Here's an example of lateral movement. And there was no difference between those that moved and didn't move, other than the fact that those that moved had bigger aneurysms. Sort of makes sense. You got more space in the aneurysm sac, and they were about 1 centimeter larger, and so that there was more space to move. And if you compared the suprarenal versus infrarenal devices, there was also no difference, and there was no, in other words, the findings were the same. Didn't matter whether you had a suprarenal or an infrarenal device. And the patients who had lateral movement had significantly larger aneurysms. And what was happening in the middle portion of the graft that you could see very easily on cross-sectional imaging was directly related to what was happening on the longitudinal analysis and the centerline path analysis. So, did it mean anything? Does it matter whether or not this thing moves? So we looked at adverse events at both 1 year and in the long term. So 1 year later, there was really no difference. Even though it had moved half a centimeter or more, there was no difference between the type 1 endoleak and secondary intervention rate. There were no conversions, no ruptures in either of the groups. That's at 1 year. You follow those same patients out now to 4.5 years, and one of them out to 8.5 years. We find now that those differences are significant, and those that had lateral movement within the aneurysm sac, 50% had type 1 endoleaks, and 75% required secondary interventions. Although these are not statistically significant, 2 of those patients had conversions to open repair, and 1 patient who had an enlargement from 6 to 8 centimeters and refused recommended conversion to open repair did rupture. So although not statistically significant, all of these major adverse events happened in those that had lateral movement. So lateral endograft movement seems to be an indicator of stent graft instability. This is a 1-year study. And the risk is higher with a larger aneurysm, and it's related to late clinical events. So what does this mean? So can we get some numbers on this? Can we do some computational analysis? Well, people have been doing computational analyses to try to look at displacement forces on endografts, and this is one such analysis. This analysis shows that there is a downward displacement force of 2 newtons. The analysis uses a rather coarse mesh, and it is not really very precise because it's missing the iliac, superior mesenteric, right and left renal arteries. It has just the outflow of the iliac arteries. It's idealized in that this is a simple planar geometry. When we think about endografts, we're always thinking about looking at the front, not looking at from the side. And so we take a kind of a planar view, and that's what's done in this analysis. And in this planar analysis of a straight bifurcated graft, the force analysis reveals the drag force of 2 newtons straight down, just like in the experimental studies, just like I've always thought about it, about the downward displacement force. Well, but actually, if you look at it from the side, you see that most aneurysms and most endografts actually bow anteriorly. The aorta is not straight. You have a big iliac curve, and there's a lot of tortuosity and angulation. Charlie Taylor's lab has been a leader in computational analysis and set out to look at this problem in terms of modeling displacement forces from patient-specific computational models built on CT scans. And I've got to give credit to Alberto Figueroa, who is sitting here in the audience, for the primary work on this analysis. and he used very realistic boundary conditions obtained from phase contrast MRI with realistic pulsatile flow and computed the physiologic flow profiles. So in this analysis, there is the celiac artery, superior mesenteric. This particular patient happens to have two renal arteries, and a very high quality mesh, physiologic flow simulation, and realistic boundary conditions for the branches. And I guess this did not, load up on the computer, the flow. In any case, this is supposed to show a flow simulation. But it shows that the inflow pressures, the left renal pressure, the right iliac pressure, and here we have the flows that are simulated in this computational model. And here in the endograft analysis, we see this is now with an endograft in place, and I hope that this, unfortunately these do not load up properly. What the important point is this arrow here. This is the force vector analysis arrow, and the movie shows this enlarging in this direction to a very great extent. And here we see the pulsatile component of the force analysis, but the vector of the force is not downward. The vector of the force is to the side. So it's a lateral displacement force, not a downward displacement force. And if you look at the total force, 4.7 newtons, the sideways component is 4.6 newtons. And the downward component is only 1.2 newtons. And here in the sagittal view, you see a kind of an anterior vector and a coronal view to the side. And this is the axial view looking from the top. You see the aorta here. You see how it bows anteriorly. The iliac's going back. And this is the force vector. So that's what's working on the endograft. And if you straighten that out, if you now reduce the angulation, you reduce the displacement forces. The total force goes down by 10%. The sideways component is still a lot more than the downward component, but the vectors change, and it's very dependent on the angulation. If you had more angulation, you'd have a lot more sideways force. If you have less angulation, you have less, but you can't escape the curvature of the iliacs, and no aorta is planar and straight. So displacement force acting on endografts are greatly influenced by geometry and angulation. And endografts in curved geometries, which are all aortas, are exposed to sideways forces, not downward components. And of course, if you have less angulation, you'll have less sideways forces. So what does that translate? You've got an endograft that looks great. Here it is, post-op. Here it is at 1 year. Here it is at 2 years. But after years and years and years of an anterior displacement force, 5 years later, it starts to bulge, and 7 years later, it starts to bulge even more. The aneurysm still hasn't changed in size. It's still 5.5 centimeters. There's no endoleak. But clearly, the force vector has had a cumulative effect over the years. Now, if you know the force vector, you start looking at things in a different way. So now let's look at all of the endograft migrations for all of the devices here. Here's an Anurex device, and you can see the sideways migration here. Here's a Zenith device. It's nice and straight here. Now when it migrates, you see how it's angulated here? And here's where it's migrated. This is an Ancure device with hooks here. You see how it's angulated over here? And so that sideways displacement force is acting on all endografts. Doesn't matter if you have hooks or barbs or suprarenal or infrarenal, the force vector is the same. You start reading the literature a little bit different. So here's a publication of a suprarenal device with its migration. Here's a superior mesenteric artery, and here you can see it's migrated. But now you look at the body of the endograft. Here's the aneurysm. See how it's moved anteriorly. Here's another one. You see how it's moved to the side. So the movement in the center portion of the graft, of course, translates its effect to the top of the graft, no matter what kind of a fixation device you have. Here's another suprarenal device. You can see the large space in the aneurysm sac, and you see the anterior movement of the device as the device migrates. And here's that patient that 1999 I showed at the FDA with the bad iliac fixation and no endo leak, and this was our great success back then. 6 months later, no endo leak, everything looked great. 2 years later, the top of the device didn't migrate, but that same sideways lateral vector of force pulled the iliac limb up. Right? So you can push to the side and either the top comes down or the bottom comes up. And in this case, the iliac limb came up, and we put iliac extenders and corrected the problem. But at least now we sort of are starting to understand what's happening and what the vectors and the forces that are acting on the devices. So as we're starting to consider future designs for devices, computation analysis will become a very important part and component of the process. And we will be able to do patient-specific predictive analyses. We'll design devices that will be able to counteract the displacement forces, and they are sideways forces. And Ron showed this slide, and as you can see, the large empty space, you can just imagine if now over those 7 years you had put something into that aneurysm sac, you could have opposed that force, and 7 years later, perhaps that would not have happened. And there are devices that are now being developed. This is one such device that's under development in terms of now filling up the aneurysm space with a polymer in a bag that now actually closes that space, maintains a lumen for blood flow, and prevents the lateral movement. And so if you now fix this within the body and you take away the potential for sideways movement, that device should not move regardless of the proximal and distal fixation forces. So with that I will end, and thank you for your attention.
We have time for a few questions. I just to prevent confusion, I want to point out that when Chris shows that distribution of patients' aneurysm size, those are patients referred for treatment on a clinical trial, not through screening, because under screening studies, there's 10 times more patients with aneurysms less than 5 centimeters in diameter than those greater than 5 centimeters in diameter, and that was a subset of that's a distribution size of the 973 patients referred for treatment in the ANUREX clinical trial.
Right, and those size distributions are about the same for all of the trials. So it's a difference of whether you're talking about treated patients or untreated patients, but the mean distribution numbers are remarkably similar. The mean aneurysms treated size 5.5 to 6 centimeters in almost all of the trials.
Yeah, and that's based on the clinical data we've already discussed. The other thing I'd point out is that the data that you have based on risk of migration based on size criteria, or success of the device based on size criteria, as well as iliac fixation, was based on the data just from the one device trial. Isn't that correct?
Right.
That's not, so that may not be germane to all devices. It's germane to one device in particular.
Well, there was one of the studies was on 2 devices.
Okay.
One with a suprarenal, one with an infrarenal fixation.
And the movement slide, that was through 2 years of follow-up, I believe. And I think our clinical concern has come up in the later years for all devices, that it's important, as I mentioned in my talk, at the out years. Is that pouch device you're showing, that's not the trivascular device, that's another pouch device? So
it's not the trivascular,
so
it's something else.
So there was a trivascular, there was a device that was being trialed that would fill up the lumen, and there were some issues with device failure, and that device was withdrawn from development.
Yeah, but just because a device fails doesn't mean the idea is wrong.
No, of course.
So it just means maybe it needs to be done better, and maybe there were some issues related to it. So I think that the issue is that if you understand the concept and what you're trying to accomplish, then you'll figure out a way to do it. And maybe the first iteration won't be the exact correct one, but sooner or later, the devices that will actually properly reflect the force distribution and respond to it will probably do a whole lot better than the ones that don't.
So, I think that that angulation displacement analysis is really essential to device design. It's just interesting that we've just come upon that now. 10 years into the EVAR, 15 years into the EVAR era. I think there's a lot of forces acting on endografts that aren't well described at the current time and are essential for designing the next generation of devices. Does anyone else have any questions, other than my many questions? Does anyone else have any questions for Dr. Zarins at all? Yeah, Dr. Raghavan?
Between your lateral movement group and the no lateral movement group, what was the incidence of distal migration of the proximal end of the graft? Did all the ones...
The lateral movement was actually a better predictor than the longitudinal centerline movement distance, but they were correlated. They were very directly correlated because, if the device doesn't elongate or shorten,
Right.
and if it bows out, then the top has to come down or the bottom has to come up.
So I presume it's 100% of the grafts that had lateral movement also had distal migration. But on the other hand, of the grafts that did not have lateral movement, what percentage had distal migration?
Minimal.
I guess
less than the cutoff. There were no clinically significant migrations. There may have been 1 or 2 millimeter movements, but
okay, so
none that met any clinical criteria of significance.
So could it be that the lateral movement is not causative of the distal movement, but rather the distal movement is causative of the lateral movement? I understand the computational study seems to make the case for perhaps a lateral movement being causative of the distal movement, but could it be the other way around? Could it be that, in fact, it's the downward force that is causing the distal movement, and because the graft cannot extend, that's naturally causing the graft to have a lateral movement?
Yeah, so that's a good question, and it's theoretically possible, but then you're presuming that the force that's moving it down is the shear force. And the shear force, that is the drag force along the lumen, is so minuscule compared to the lateral force. I mean, it's orders of magnitude less. So then the question is, what would be the force that's actually causing that displacement? And the shear forces are just so tiny that it begs the question of what is it that's the force that's causing it to happen.
I think I'd like to get in on that. That's not necessarily a true statement. There would have to be shear forces that would drag the stent down. That would only be true if the stent was straight. But if the stent has curvature, then there can be normal forces that are in the downward direction too. So it's not quite as simple as you're making out.
Well, there is a component of downward, but the predominant component is to the side. There is an element of downward component. But it's basically pressure related rather than shear related. In other words, the drag shear related force is very different. Charlie, maybe you want to comment on it?
That's right. It's a total traction force that's computed, but it's the curvature causes the traction force to be, predominantly transverse rather than axial.
Can I, what do...
Viscous drag is
Okay,
small.
another way of looking at
Viscous
this.
drag is small.
Yeah, I understand what you're saying, but you showed the force vector in the early plots, and it wasn't lateral. It had some deviation in the axial direction, right? So that tells you that there is some significant component of force in the axial direction.
Yeah, we quantified it, and it's much smaller than the transverse.
It's not negligible, though.
No, but it's small compared to there's another force in the lateral direction that is larger.
So another observation relevant to that is that some aneurysms shrink after the endograft is placed, and some don't. And we're not quite sure still what the differences are, even within subset of patients with no endo leaks. And presumably, sometimes that shrinkage actually displaces the EVAR device. It either forces it out or compacts it or something like that. Other times, sometimes you can stabilize the device to reduce those lateral forces. So I think, in terms of device design, you'd also have to consider intermediate and late-term changes to the shape of the aneurysm after the device has actually been placed, should factor into the predictions as well, I think. Chris, do
Well,
you have a comment?
we actually saw lateral movement in both aneurysms that change in size and those that did not change in size. So it did not seem that the lateral movement was being caused by the change in aneurysm size. It may have been coincidental, and some of them, the aneurysms were exactly the same. That one patient, 7 years, 5.5 centimeters, exactly the same for 7 years, but there was very significant movement of the device over that 7-year period. I don't think I think they're independent and different processes going on. Although the large aneurysm size provides this greater propensity to move because there's more room and space for that endograft to move.
Yeah,
I'm curious to know what happens to the contents of the aneurysm sac structurally after implantation of the device. So if it solidifies, quote unquote, then even if there's a curvature, there will be enough support not to make it move laterally. So any thoughts on what happens to the contents inside from a mechanical structure point of view?
Yeah, I don't know because we've done a couple of open repairs, and basically if you open up the contents is mural thrombus. Mural thrombus doesn't have a whole lot of structural strength to it and can probably remodel and change over time, but I think in terms of a structural component to withstand or oppose the thing, I don't think the mural thrombus is probably going to do a whole lot.
The preceding program is copyrighted by Stanford University. Please visit us at stanford.edu.